Welcome. This is the final part 3 of preeclampsia, and what we try to do now is, after discussing the clinical presentation, the management, the pathogenesis, that I would like to offer you 6 different cases to manage. Do realize I will give you an answer, and do realize it's never a black and white answer. It's always looking at the individual woman in front of you, and those individual factors could sometimes make a difference in making a decision. It's never black and white. That's the challenging and at the same time the beautiful part of being an obstetrician. Case 1. How would you manage a primary gravida with a blood pressure of 136/86 at a gestational age of 34 weeks? By the way, she has no preeclampsia risk factors other than being a primary gravida and 34 weeks, and she has no symptoms whatsoever. I think, reflect on this for a few seconds. It's important to check what the blood pressure was at booking, whether we are dealing with a pre-existing hypertension or not. That was not the case in this particular lady. At this stage, there is no medical treatment required. This blood pressure is still below the 140/90 cutoff point, but I think it's good to ask yourself, what do we know about the fetal growth? I would be inclined in this particular lady to check her uncomplicated preeclampsia bloods and urine to take stock of potential organ damage, which might be flying under the radar. And I would arrange a next antenatal visit a bit earlier than usual, in 1 week's time. I always would explain to her to present earlier if she would have possible symptoms, and that's quite subtle because you don't want to scare her on one hand, and on the other hand you want her to be aware of certain symptoms. That would be case 1. So be extra vigilant without going overboard and starting to give her antihypertensive medication. Case 2. A 37-year-old primary gravida carries a dichorionic diamniotic twin. She is 34 weeks and a few days pregnant, and you measure a blood pressure of 140/90. She is asymptomatic otherwise. An ultrasound scan 1 week ago showed that both fetuses were in cephalic position presentation and were appropriate for gestational age, so no growth restriction. When you check the blood pressure 10 minutes later, the blood pressure is now 140/85. How would you manage her? Think about this for a few seconds. What we have to realize, we are dealing with 3 different risk factors. A primary gravida with a twin pregnancy at a gestational age of 34 weeks. So we have to take this quite seriously. That means, check blood and urine and see her more frequently. The blood and urine will tell us whether we are dealing with early preeclampsia here as well. But this lady, of course, needs further attention, and depending on the blood results, we would like to admit her, or we would like to see her twice weekly on an outpatient basis. So here there is not a black and white answer. But of course, 3 risk factors mean you must take this seriously. It would be not appropriate just to say, okay, the second blood pressure reading is just about right, so no worries, go away, go home and come back in 1 week. That would be somewhat naive. Case 3. A 25-year-old primary gravida with a gestational age of 34 weeks presents with severe headache. Her blood pressure is 170/110. How would you manage her? Of course, what you can do immediately is check the reflexes, and in this situation her deep tendon reflexes were brisk and she had 3 pluses of clonus. Wow, this is severe preeclampsia. So take seriously, admit her, and she should be given blood pressure lowering medication immediately. Ideally intravenously labetalol or hydralazine, or if not available or not possible, you could give her oral nifedipine. That's an option, for instance, when the patient is not in a hospital setting. Give her oral nifedipine immediately, don't wait. Well, what are the risks if we drop the blood pressure very quickly due to IV administration of, for instance, labetalol? Well, we might not, by lowering the maternal blood pressure successfully, we could also reduce the placental perfusion. And if this baby was already IAGR, that could mean we deprive the baby from further, via the placenta, from further perfusion. So it could result in abnormal fetal heart rate on a CTG. So continuous fetal heart rate monitoring with the CTG is essential. In this scenario, by the way, we should not only give the mother labetalol, that's the first measure. The second measure is that we administer 4 grams of magnesium sulfate either intravenously or intramuscularly. This is not that the only important reason to do this is to prevent the mother from having eclamptic fit, eclamptic generalized tonic-clonic seizures. So this case should raise the alarm for every antenatal care provider. This is a case where we must treat aggressively to reduce the likelihood of severe complications. Now another case, we have here an asymptomatic woman, pregnant woman, 19 years of age, primary gravida. And asymptomatic in this example means she has no signs or symptoms of preeclampsia, or she has no bruising or spontaneous bleeding, such as nose bleeding, at the gestational age of 36 weeks and 2 days. And she has a blood pressure of 115/75, normal blood pressure. A full blood count showed a normal hemoglobin and a platelet count of 120, whilst the norm should be more than 150,000. All other bloods and urine results were absolutely normal, so not pointing at any preeclampsia whatsoever. Yet, at booking, her platelet count was 175,000. What is going on here? The diagnosis made here is gestational thrombocytopenia. There is no signs of preeclampsia. So, this case, in principle, gestational thrombocytopenia is not dangerous for the mother and or her fetus. However, there is one thing we need to consider. When this lady would like to have an epidural block for analgesia during labor, that we have to be careful that the platelet count is in a safe range. Usually, the anesthetist, most anesthetists will be happy to establish an epidural block if the platelet count is more than 80,000, but of course, it's the prerogative of the anesthetist. So this is a condition which is self-limiting, and the platelets will recover after pregnancy to the normal range. Has no consequences, there's no increased risk for fetal intracerebral hemorrhage, for instance. The fifth case, we are dealing now with a 36-year-old primary gravida. She's 12 weeks pregnant, has a BMI of 32, and we measure a blood pressure of 150/100. This is now a situation that points at a pre-existing hypertension. So, this lady, we should check her baseline preeclampsia bloods and urine and look for organ damage, or for instance pre-existing proteinuria, and we would start an antihypertensive drug here. The drug of choice, there are 2 options. Alpha-methyl-dopa is a good oldie, which can be given in a dose of 250 to 750 milligrams 3 times a day. It's a central working agent. It works by reducing the systemic vascular resistance. Or we can give her labetalol, 100 to 400 milligrams 3 times a day. Labetalol is a beta blocker with a mild alpha vasodilator effect. Important for doctors who are not familiar with antenatal care that we should avoid ACE inhibitors. They are Cat-D drugs, so absolutely indicated to use in pregnancy. They have resulted in fetal death, in renal failure, and the same applies to diuretics, which are category 3C drug. So ACE inhibitors and diuretics have no place in the treatment of high blood pressure in pregnancy, and that's in contrast with non-pregnant individuals. That's an important lesson to take on board here. Let's now move to the last case, case 6. Now we're dealing with a gravid 2 pair 1. She is 10 weeks pregnant. Her first pregnancy was complicated by severe preeclampsia at 36 weeks, and pregnancy was induced, and a healthy baby boy of 2.8 kilos was born. That was for her an appropriate for gestational age baby, so non-IAGR baby. What should you do or could you do to reduce the likelihood of preeclampsia reoccurring for her? There is good evidence that the administration of 100 milligrams or 150 milligrams of aspirin taken at night reduces her likelihood by, we can see, by 14%. Significantly lower risk for preeclampsia according to the Paris meta-analysis. Another option is to the consideration is to give her calcium, 1 for 5 grams a day. According to a recent Cochrane review, that reduces the likelihood of preeclampsia reoccurring by 52%, which is also significant. Both reviews involved a large amount of women. So this is only useful if there is a low calcium intake, which is the case in Australia. By the way, of notice in this Cochrane review, there were nil women with previous preeclampsia included, so they were excluded from this analysis. So this is the last slide of the preeclampsia trilogy. So preeclampsia, think system and systematically. Thank you for your attention and putting up with me for not 1, not 2, but even 3 parts to discuss this fascinating, intriguing, and potentially dangerous preeclampsia. I hope that our women will benefit, that you will be more confident, competent, and as always, caring about mother and her child. Cheers!